5 4. Awesome. And we are live. Good morning, Doc. I appreciate you jumping on, and I'll let you just roll with an introduction. Tell obviously everybody a little bit about yourself, which you shouldn't need a whole lot of introduction, but um, 3, 2, 1, go.
Well, the first thing that occurs to me is just last month was my 50th year seeing patients and practicing medicine.
That's so
So
awesome.
during
Absolutely
that
incredible.
time, I've survived a couple of medical boards. I've survived thousands and thousands of patients, survived the FDA, whatever. Uh, I started off as an emergency room doc, and uh, and after about 8 years of that, sort of got tired of the hours and the stress and such. So I decided I'd just start doing general medicine. And at that point, I was very naive. Anyhow, I actually thought that everything you needed to know about medicine they taught you in medical school. I mean, how naive can
Yeah.
you be to believe that? But anyhow, that's what I thought. And so I just went out and hung up my shingle and started treating patients. And after about 3 months, I went to the head of the Department of Medicine there at the hospital I was working at, and I said, I don't know what's wrong with me. Maybe I don't know what I'm doing. But every patient I see, I'm giving them these medications. They never actually get well. And half the time they get sick from the medicine. And tell me what I'm doing wrong. So he said, okay. So we went over everything that I was doing. And the gist of it is he comes back and he says, yeah, you're doing okay. And I said, yeah, but nobody ever gets better. And then we have all these complications from the drugs. He says, yeah, well, that's the way it works. We're not trying to actually make them better per se. We're just trying to give them some comfort and alleviate some of their symptoms, make their lives a little bit better. And if they get better, that's great. If they don't, that's great too. But so is at that my eyes were opened at that point. And I thought, you know what? This isn't the way we used to do emergency medicine. Heck, if I did emergency medicine like this, guy would come in with a gunshot wound, and instead of like repairing the wound, I'd like give him an antidepressant and send them home. That's the we're not treating the cause, we're not treating the issues at hand. So anyhow, that was my eye opener, and that was back in the late '70s. And since then, it's been a long travel. I've learned a whole lot of things that work. I've learned a whole lot of things that don't work that they don't teach us in medical school. So hopefully we'll talk about some of those things today.
Oh, I love that. What did you have anybody around you in your early years that would question things like you did, as far as like, why are we not getting to the problem? Or was this just you asking the questions and finding out that it wasn't there?
I got so lucky because I was down in the San Francisco at that time. And guess
Mm-hmm.
what? I fell into a monthly study group that met every month in San Francisco in the San Francisco University of California library, right there on Parnassus Street, which has 18 billion books in there, and they go all the way back to the 1700s. Just amazing. And we would meet
Wow.
there once a month, and just we just wander around the bookshelves and start pulling out stuff, and then for about an hour and a half, then we'd all come back and tell each other what we found. And one of the members in that group was a guy that most people have heard of by the name of Linus Pauling. Another
Yes.
member of that group was Dick Cunyon, who maybe not a lot of people have heard about, but he was one of the big pioneers in alternative medicine in the early days. Julian Whitaker was in there. Jonathan Wright with us periodically. So we had big guys. And I was
Yeah.
sort of the neophyte at that time. And I just got lucky. Another medical school.
Oh, there we go. We got a little latency there. That's okay. Um,
Can you?
what
Okay.
What tell me about Linus Pauling. What was it like just being in his space for a little while? There you go.
Yeah. So I don't know. Some said something's wrong with the internet connection or something.
That's okay. It'll all
My
splice together.
little internet thing says it's okay, so I don't know. Okay. Yeah. So um, okay. So we just keep going.
Yeah, that's fine. We'll splice it all together. It'll actually be seamless. So
Okay. All right. Nothing looks right on my end in the sense of everything's frozen and I can't hear you half the time.
yeah, that's a bummer. I don't know if it's might be your internet, but
Well, the signal says it's strong.
is it? Okay. Because I'm getting you loud and clear, but
Oh, really? Okay.
yeah.
All right. Well, let's try it again. Everything seems to be okay right now. But you were asking me about Linus Pauling. I got a
Yes.
great Linus Pauling story. You'll love this. So
Good.
Linus comes in. Linus comes in one day, and of course, everybody stands in awe of the guy. So he can do whatever he wants. He can say whatever he wants. He's that guy.
Yeah.
And so he comes in. He says, "You know what? I've been thinking about urine therapy." And we all start looking at each other. Urine therapy? What's that all about? So he says, "Yeah, I've been studying up on it, and I've got some ideas on it." And so that in those days, we had a big old chalkboard. So he goes up to the chalkboard, and he starts writing on the chalkboard. And he says, "I found out this, this, and this," and he's writing all this stuff on the chalkboard. And then he's drawn some kind of arrow or something, and he says, "And then I found out this and this and this, and I reasoned that this would happen," and so forth. And this talk goes on for like 45 minutes. And during the course of that he's like off on all these tangents, and I'm thinking to myself, well, okay, he's getting pretty old. Maybe he's losing it a little bit or something. So but the remarkable thing and the thing that made me just like my jaw dropped open. It was after about 45, 50 minutes, all these pieces of information, he tied it together beautifully in about 3 minutes. And made a serious case for all these things that his brain could like track all this stuff. It was astounding to me at
Wow.
that time. I'll never forget it.
Yeah, something to bring together, and then something that he implemented.
Well, I don't know that he ever implemented it. Years later, by the way, like 20 years later, I actually started to understand urine therapy and get into urine therapy.
Yeah.
And today, to a degree, I actually still use it.
Wow.
And it's really quite interesting. But at the time, it was like whatever. I mean, I was like a kid going in and getting all this information I never heard before. So it was like I was just whatever. I just shut up and listen.
Yeah, absorb what nowadays would be considered conspiracy stuff, right?
Yeah.
Well, tell me, it's kind of relevant just with how you've been a pioneer in a lot of different things and some of the heat that you've taken with the medical boards. How just briefly, how did you navigate some of that, other than lawyers, I guess?
Uh, it's just a struggle. It's a struggle as far as I'm concerned. It's a struggle between truth and lies. It's a struggle between good and evil. It's a struggle between pharma and the rest of us. It's just a struggle. And fortunately, we live in a pretty good country, and I live in a pretty good
Yeah,
state that gives us a lot more freedom than there are in other areas of the world. That's for sure. But
yeah.
you play the game, you're going to take your hits, and that's the way it is. But if you want to play the game, that's what we do.
I did a presentation just the other night. We were talking about sports nutrition for our local group, and but it was astounding that when I brought up a scenario of the big corporations owning most of it, and Blackstock and Vanguard were the two major corporations that have the largest shares, and we're talking billions and billions of dollars in Apple, Microsoft, Google, but then it goes into J&J, it goes into Moderna, it goes into Pfizer, and they literally have the majority of
Mm.
voting rights on those things and how it goes. But not a path that we need to go down, but definitely explains doing some things a little bit off the beaten path. I really would love to dive into your pioneering of anti-aging and what you've done along those lines, and of course the mitochondrial health and expanding that,
Okay.
if you don't mind, just going into that.
About 30 years ago, I was riding my bike. It was one morning I was riding my bike to work, and it's a long ride, and you ride your bike and your mind goes all over the place, sort of free floats around. And I was thinking about the fact that as we get older, we have less energy. And I'd been reading about that, where you can measure energy output vis-a-vis VO2 testing. And, uh, and, and I'm thinking, yeah, you get older, you have less energy. You get older, you have less energy. And then somehow this thought came into my head. I said, what if the reason you get older is because you have less energy? What if the less energy part comes first and then the aging starts, instead of the less energy part being a result of the aging process? What
Hmm.
if I age, and by the term aging, I'm not just talking about how many birthdays you have. I'm talking about how you function. So, as we get older, we don't function as well. Everybody knows that. So, but
Hmm.
and but my thought was, what if that's all determined preemptively by how you produce energy? And because I'm thinking of a flashlight, you got a perfectly good flashlight, and battery goes bad. Well, how good does that flashlight work? Don't work good. The problem is not the flashlight. The problem is the battery. So
Absolutely.
anyhow, I was just free floating that idea. So I got to work, and over the next few days, I started thinking, I need to start measuring energy production in people, because that'll tell me, what's going on. And so I started trying to figure out various ways to measure energy production. And there's a number of ways out there that have been used experimentally and in research and such like that. But the only one that really came to me that was viable in the way that I could use it without having to stick needles into people's arteries or get very complicated pieces of equipment was to look at oxygen consumption. Because the point is this: all our energy production comes from oxygen. That's where it comes from.
Yes.
So oxygen is a high energy molecule. It's kind of like gasoline is to a car, if you will. So we put oxygen into our systems. Our cells are able to extract the energy from oxygen, and then we can harness that energy, and that's what allows us to work, allows the cells to work and all the organs to function, is that energy that we get from oxygen. So pretty much, like 99 point something percent of all the oxygen that we take in simply goes to energy production, doesn't go anywhere else. So that's pretty simple then. If all the oxygen goes into
Yeah.
energy production, all you need to do is measure how much oxygen a person is consuming, and you can determine with some formulas. The formulas are all established and out there, but you can determine with these formulas how much energy they're producing. So I started doing it. So I went out and bought the equipment. It was kind of expensive at the time. My wife was like not
Hmm.
entirely happy with my project here. But anyway, we bought this equipment and I'm starting measuring energy production on people. And I'm measuring by measuring how much oxygen they're consuming. Now, these are devices, by the way, that have been used in medicine for like 50, 60 years, these devices. The 50, 60 years ago, they were big old huge devices that only like university centers could afford. Nowadays, because of some of the things they've had to do with NASA, they made tiny little ones that were all digital and really cool. So these are things that we could actually use in real practice. And they use them in hospitals. And they'll use them in hospitals to determine, who needs a heart transplant or how bad your lungs are or things like that. And they also use them in Olympic training centers to determine, if some guy comes in and says, I want to be on the Olympic team, they'll run him through some of this oxygen consumption data. And based upon that, they'll say, forget it. You're not in that quality. You don't stand a chance. And then they'll use it as part of their training programs. So here I get this equipment. I start doing it on everybody, doing it on myself, doing my next door neighbor, my wife, patients that come in. I'm just
Hmm.
doing all this tests. And finally I end up calling the guy up that sold me the equipment. And I said, there's something wrong with your equipment. And he says, what do you mean? I said, everybody that I'm testing, not everybody. He said, but like I test some people and their oxygen consumption is horrible and they look completely normal. And he says, well, it sounds like something's wrong with my equipment. I said, okay, fine. So he comes on out, he checks the equipment. He says, no, everything's good. And so then we sat down, we started thinking, well, what could be wrong? And a couple weeks later, it occurred to me, what's wrong? Is all the data that establishes what's normal and what you should see on this form of testing, all the data that's on that has to do with two very disparate groups of people. One is Olympic quality athletes. There's lots of data on them. And two,
Yeah.
people that need heart transplants. There's lots of data on them. But in terms of Joe Lunchbox, everyday abnormal people, there's no data on them. And so that's why nothing matched out. That's why we couldn't understand at the time, because nobody was actually measuring oxygen consumption on normal people. So I started measuring it on normal people. And what I found out pretty quickly was there's a whole lot of people out there that, are asymptomatic. They feel good. In other words, they're getting around just fine. They don't have any complaints, have very poor oxygen consumption. Very poor, sometimes substantially poor. In some cases, we did a study in 2004 on this, and we found out, we did a group of people between the ages of 30 and 40 that were asymptomatic. There a total of 40 of them, men and women, asymptomatic between 30 and 40. And something like 16, 17% of them had such poor oxygen consumption that they would have been eligible for disability.
Wow.
And at that point, I said, you know what? Who's going to get sick? Who's going to get sick first? And in that group of 40 people, who am I betting on is going to get cancer or diabetes or heart disease? I'm betting on the 16%, because they can't make the energy to have their cells function properly, and they're doing this at an early age, and sooner or later they're going to fall apart. And my goal, Todd, is, even though I spend too much of my time treating sick people, my goal is that doctors, for the most part, should never treat sick people. We should treat well people and make sure they never get sick. We should
Yes.
establish proactive sorts of ways to deal with their patients, so that on an ideal day, every patient I see would be somebody like that. They come and say, I don't have a problem. I feel good. I check their energy consumption. If their energy production is super good, I say, fine, you're in great shape. Just keep doing what you're doing. But if they don't do well on that test, that I say, you know what? You are now set up to have problems down the line. Next 5, 10, 20 years, you're going to have problems if we don't straighten this out. So let's straighten it out. So I get to be proactive and preemptive on this and go in there and straighten them out. And I'm not happy until I get a person. Every one of my patients needs to have really good energy production. And if they do that, the statistics are amazing. You just don't get sick. Nothing ever actually gets to you if you've got good energy production. Because the biggest difference between you and me when we're 20 years old and when we're 70 years old is energy production. That's the big difference. And that's what determines how well we function. So that's the thing that just drives me and has driven me for many, many years, is try to figure out, if somebody has poor energy production, how do you maximize it? How do you, what's going wrong?
That's incredible. So you have an objective measure that puts people then, based on everything that you've gathered, into different categories that you can essentially predict their outcomes long term, or the four horsemen, as we say in medicine, of the medical apocalypse that are going to settle in: cancer, diabetes, what have you. So that's cool. I was close in that, and I'll say this. I'll say this on the podcast. That's fine. I want to get that. I know I talked to your wife briefly about learning your systems and stuff, but I'd love to take that and run with it too. Because I agree, if the body doesn't have that energy, we're seeing it break down all the time. So then your goals become clinically to improve that oxygen consumption. Can you walk through that and expand basically what you're using, some of the techniques to obviously get into mitochondrial enhancement, right?
Yeah. So let me just first say, before I forget,
Yeah.
I did produce a YouTube series on this. And
Okay.
it's a series of 5 little vignettes that are about like 12 minutes each. And I walk through people through the whole version of the testing. And people can learn this if they go onto YouTube and plug in the search engine Shallenberger disease is optional. Shallenberger disease is optional. These vignettes will pop up and they can learn all about it. But basically, what it amounts to is it's a device like a scuba mask,
Mm-hmm.
and you wear it, and it's connected to an analyzer, and the analyzer is analyzing 2 things: 1, how much oxygen you're consuming, and 2, how much carbon dioxide you're producing. The amount of oxygen you're consuming is directly related to your mitochondrial function and your energy production. The amount of CO2 you're producing is directly related to both your diet, the status of your lungs, and the efficiency at which your cells generate energy. So it's how much energy and how efficient are they. So by getting those 2 readings, I can put them through a whole bunch of known algorithms. They're not mine, but these are all published algorithms. I can put that data through a bunch of known algorithms and come up with just a bunch of fascinating information, where it's almost like if you were to come to my clinic and I would look at the results of this test on you, I almost don't even need to talk to you or see you to tell you what you need to do. Because I know so much about how your body works just from looking at that test. But we have you come
Wow.
in, you sit down for about 10 minutes, and just sitting quietly, we get all your resting metabolic data. And then we put you on a bicycle and we make you work harder and harder on this bicycle. And as you're working harder and harder, obviously you need more and more energy. You got to consume more and more oxygen. So the technicians seeing that oxygen consumption go up in a linear kind of fashion, and seeing the CO2 production go up linear. Well, at some point, when you reach your maximum mitochondrial capacity, the CO2 takes a sharp upward turn, and the O2 consumption stops and starts going down.
Yep. Opposite.
And where that crosses, we measure that point. So that's your maximum energy production. We measure that point. And what then I do is I take that point and I compare it to a database of healthy 40-year-old men and women. And And basically, I don't care how old my patients are. I want them to be as good as at least a 40-year-old. But most of them, I tell you, if you take care of business, a lot of my patients are like 80 years old, and they have the energy function of like a 32-year-old guy.
Wow.
Yeah, it's not that hard to do. But if they come back and they're, there's a problem. A lot of the times, just from your history, looking at what medications they're on, or what's going on in their life with their diet, like, etc., all the regular stuff everybody looks at, heavy metals, all that. By looking at all that, you can say, okay, we got a problem here. Let's now dig and see if we can't find out how to solve this problem. And then we just keep doing it, and we keep repeating the test until it's A1. Once it's A1, bingo, we're on the money.
So, I'd imagine, I mean, some lifestyle changes. Of course, you're pioneering on major autohemotherapy. But walk through what that looks like for somebody. How often do you test then? Like, where's the body going to turn around quickly, or is it a 30, 60, 90-day run, or what that looks like in your clinic?
Yeah, ideally, in an ideal world, everybody would get this test when they hit 40 years old.
Okay.
They should be in pretty good shape. But like I told you, we just did that with a group of people, and like 15, 16% of them weren't okay, even at that age. So,
Jeez.
so if they're not okay, then we're going to say, okay, you think you're healthy, you feel good, but you got a problem. And that problem is going to
Hmm.
very insidiously take you down over the next 5 to 10
Yeah.
years. So let's correct that problem right now. Now, most of the time that I find that there's problems, most of the time it's correctable by getting them off mitochondrial suppressant drugs. They may be on them. A lot of the drugs that are FDA approved are actually mitochondrial suppressants. Statins would be an example. A
I was
lot of
going
the
to say
diabetes
statins for.
drugs are. Yeah, statins are mitochondrial suppressants for a lot of people. So are antidepressants. So are beta blockers. So are a lot of the diabetes drugs. Now everybody's
And the
different, so
mech.
you can give a drug to one person and it won't suppress their energy production, and you give the same drug to another person and it will. That's because we're different.
Wow.
But so we look at things like that. But really the thing that comes through most of the time is they're not exercising, they're not
Yeah.
sleeping, they're not eating properly, and they feel okay. That's the problem. They're setting the
Hmm.
stage for disease, but they feel okay for the first 10 years of setting the stage for disease. And then they get the disease, and then maybe they don't figure out, well, why did I get sick all of a sudden? You didn't get sick all of a sudden. You've been
Yeah.
getting sick for the last 10 years and you didn't know it. So we want to find out early and stop that process so you don't have to go through all this nonsense like so many people have to when they get sick. Now you're sick. Now we got a whole nother level of problem.
Yes. Yes. And so, back to that, I'm just curious. I mean, all the different medications probably have different mechanisms, but I know the statins, for instance, will wash out CoQ10, that, the
Yeah.
cofactor that helps build energy. Is there a common theme on all those meds and what it's doing to the body, or is it different mechanisms?
There's lots of different mechanisms.
Okay. So obviously dependent, but if you have somebody that's on 3 or 4 different medications, it's a good indicator that that's all going on for sure. So, um,
Yeah, it's an interesting thing. I like to point it out to my fellow colleagues whenever I can, and that is that Sir William Osler, and I don't know if everybody's heard of Sir William Osler, but he was the first head of the Department of Medicine at Johns Hopkins University in the late 1800s, early 1900s. And he wrote a number of books, and he is considered by all the medical schools as the father of modern medicine, Sir William
sure.
Osler. And one of
Hmm.
his quotes is, and this is a real quote, one of his quotes was from one of his magazines, was that the first duty of a physician is to take his patient off drugs.
Wow.
And I talked to my colleagues today and I say, you know what? The old man is rolling over in his grave right now. Because you guys, I see patients with on 10, 15 drugs because of the stupid system, the way it works. They're seeing 5 different doctors, and the doctors are all throwing drugs at them, and they don't know what's going on. There is no possible way you can be on that collection of drugs and be healthy. That's basically impossible. You're not going to see that. So
Oh, for
one of our
sure.
first jobs is to, look at all these drugs. And indeed, what's interesting is a lot of patients come in and say, look, I don't want to be on these drugs. That's why I'm here.
Yes.
Give me an alternative. In fact, I'll tell you a great case. This is a good case. I had a lady come in once, and I said, what are you doing? New patient. What are you doing here? Well, oh, yeah. I said, well, what's your problem? She says, well, I'm fine. I don't have any problem. I said, well, why are you here? She says, well, 3 months ago, I felt like crap. And I was tired, run down. I was achy all over, whatever. I can't remember the exact details, but she had big problems. She said, it took me, I couldn't get in to see you very quickly. So it was like 3 or 4 months out before I could see you. And after about 2 months of waiting for you, I just got sick and tired, and I stopped all my medicines. I said, you stopped all your medicines? She said, yeah. I said, how many were you on? She said, I was on 6. I said, you stopped all your medicines without talking to your doctor or anything? She said, yeah. I said, well, what happened? She said, 2 weeks later, I felt great. And I still feel great, but I thought I'd come and see you anyway.
I just want to check.
This is what
Make
our
sure.
system is doing. It's making us sick.
Yes.
It's crazy.
Yeah, it's disastrous. I know it is for
Yeah.
sure. Did you so go down the couple years of COVID, and I know you were probably filling up with patients like we were, and people seeking, any which way that they could boost their immune system, things like that. And of course, we were having people on that major auto chemotherapy with the pulse ox, really low, and we could see the increase. And do you want to talk to the role of ozone and the implications on the mitochondria a little bit?
Yes, so for sure, and I don't want to get too I don't want to get what do I say too complicated, because there's very
Yeah.
interesting biochemical pathways that have to do with this. But let's just say that ozone's oxygen. So everybody needs to know ozone's oxygen. It's not pollution. It's not some kind of
Yes.
chemical. It's just a pure oxygen molecule. It happens to be an oxygen molecule that's pure, but way more powerful than the normal oxygen that doctors use, the kind that you breathe. Ozone, you
Hmm.
have to make it up pronto, right there on the spot. You take regular oxygen, run it through a generator box, and out the other end pops ozone. And you got to use it very quickly because it's a highly reactive form of oxygen, and it will disperse if you don't. So you manufacture right there on the step. When you put this form of oxygen into patients, it absolutely corrects a lot of things. I've written a whole book about this. There's very many things that it
Yes.
corrects, but clearly one of the things it corrects is the way that your cells are able to process oxygen. It makes your cells process oxygen better, which is why it helps all the COVID patients. Yeah,
Sure.
and I don't know. I don't know if you heard of this study by Franzini that came out of Italy early on. By the way, early on, I want to say it was in 20, sometime in 20, like October of 20, early on in the COVID epidemic. Early on, Franzini published a paper, and I won't go through all the details of the paper, but the bottom line is this: he took 50 patients who were big time sick, needed to be on respirators, big time sick. And he treated them with standard of care, which at that time was just fluids and steroids, and plus ozone therapy. So that's the only thing he different. And he had a 4% death rate. 4% death rate. In this country, with that same population of people, we have an 80% death rate. So when you look at the
Wow.
deaths that were caused by COVID in the United States of America, it's because nobody listened to Franzini. They completely ignored that. Nobody went out and did anything except nothing.
Yeah.
And
The
it's
treatment was
shocking when you
hide.
realize how bad our public health system guided us. They completely shut down the one thing that could have saved lots and lots of lives.
Yes.
And it was published. It wasn't like they didn't know. It's like they just didn't care or something.
Yeah, it was tragic.
Crazy.
Yeah, one of the worst disasters that and that'll keep coming out more and more. So,
Yeah.
ugh. Yeah, that's incredible, though, that when you have that data, but it seems to be that way in medicine, and even in my alternative world of chiropractic, it's just is some cutting edge, or even some older therapies that just don't get implemented by doctors. It's
Mm,
just like they know their routine, and that's all they will do, and not seek out some of these things like you have, being a pioneer on that. So yeah, it's too bad. It's really too bad, because yeah, it was the single biggest death rate that I've ever seen, and I've been in practice for like about 21 years now. And we were just, going through charts, and it was outrageous.
mm.
It was horrible. But um, so let's go back. I mean, so what's your, I know what your goal is, as far as somebody comes in, you get them off the medication. That's absolutely phenomenal. Got to be a first step. Get them, moving, their body moving, things like that. Are there other ways that you're treating to increase that oxygen capacity, or the mitochondrial efficiency? And I guess I'm kind of I'll play dumb on this. Do the mitochondria specifically, when you start increasing these things do they increase in number? Do they increase in efficiency normally, I guess?
Yeah. Okay. So the bad news is that there is a point of no return. So if people wait too darn long, we can't turn it around.
Okay,
We call it mitochondrial decay. They're past the point of a return. Fortunately, most people aren't in that bag, but people should know that they can't keep going on this indefinitely and expect that any old time when they want to change their ways, they're going to get back on the saddle again. That doesn't always happen. That
and is that
said,
something, Doc? Is that something you can measure?
yeah, oh yeah, yeah.
Okay,
I don't. I always assume that we can do something, because even if I
sure.
can't get them back to the 40-year-old top of the hill type thing, I can at least improve them. So we're going to do the same thing anyway. But it's just important people understand that one of the things we see in medicine, and as a doctor I see this all the time, is people come and see me last.
Yeah.
They go and they get all the crappy therapy first. They get poisoned by the crappy therapy, and then when it's all gone to hell, they decide, you know what? Let's try something natural. That is so backwards. It's just backwards. They should
It
see people
is.
like you and me first. And then
Mm-hmm.
if we can't do it, if we can't help them or help them out, fine. We'll throw in some drugs. We'll get into the thing, but it's just they got it backwards. But anyway, to get more into your question, when they're really hurting with their energy production, things that work out really well is intravenous ozone therapy, like you were just talking about, heavy detoxification. So you can detoxify with colonics, and you can detoxify with colonics using ozone, which we do a lot. You can use light
Insufflation.
therapies, red light therapies, laser therapies. We can use intravenous vitamin C. We do a lot of chelation and detoxification of heavy metals. And these are the kinds of interventions. And yeah, and then herbs. And then you say, okay, I want you to improve your energy production. But guess what? Energy production, think of a car. So, the engine's not running right. In fact, that's actually a good analogy. So somebody wants to go buy a car, and they want to know, how good is this car? Well, they could look at each individual spark plug. They could look at each individual tire. They could look at each individual carburetor or fuel injector. They could look at each individual part. But hey, how about this? How about just take it out on the track and run it? If it's running at 150 miles an hour and taking the corners pretty good, it's a pretty good car. I think we can say
Yeah.
that. It passed the test. That's kind of what bioenergy testing is like. It tells me if the car's good. So if they come back with a poor test, now I got to dig. Now I got to find out, well, what's missing in this? Because sometimes it could be like what you just alluded to, CoQ10. It could be they don't make enough CoQ10. It could be they don't make enough creatine phosphate. It could be they don't make enough adenosine monophosphate. It could be they don't have enough thyroid. Thyroid controls the whole darn thing. It could be they don't have enough
Hmm.
of one of the other hormones like DHEA. How about magnesium, B vitamins?
Yes.
All of these cofactors the body needs in order to be able to process that oxygen, just like the car engine needs a good fuel injector and good tires to be able to run around the track. So we need to look at all those little pieces and, and figure it all out. And we're just not going to be happy until we see some significant improvement on the road test.
Which makes some sense. Um, it brings up a good point. I'm just curious. I mean, is it is it more volatile to bring in those oxygen sources if somebody is not able to process, like you said, maybe they're deficient on magnesium or other cofactors that are in this process when, you can see, and the typical American way is like when if I'm unhealthy, maybe, and it was always fat driven, right? Weight driven. So I'm just going to go hop on a treadmill and start, sucking in oxygen and trying to make a shift in that. But in your experience, if somebody is totally deficient nutrient wise and they start going into that, doesn't that seem to be a little bit harder on the body?
Yeah, it's people have to remember to focus on the basics. You know,
Yes. Yeah.
part of the problem is sometimes somebody will like listen to a podcast or they'll pick up a magazine article and and it'll say in there that this particular supplement is just fantastic and it fixes everything in the world and and they need to understand, no, don't forget the dang supplement. If you're not getting good sleep, if you're in pain, if your body's all screwed up and all bent and twisted, if you're not exercising, if you're not eating properly, if you're a stress case, forget all that stuff. Clean those things up first. Hit the fundamentals first.
Absolutely.
Put some good
Yeah.
gasoline in the car. Make sure the
Yeah.
tires are good. Get the basics down first before you start getting into, high octane gasoline or something like that.
Well, I hope to real soon start implementing some of these things as far as the bioenergy testing. We have a workforce, largest gold mines in the world, where we are here in Elko,
Hmm.
and you're just hitting on the key points that these gentlemen and women are working these 5/4 swing shifts. So their body is just out of sleep. Even the days that they have off, their sleep's absolutely disrupted. They're
Yeah.
mechanically distorted in their frame because they lose a lot of energy bouncing up and down on these huge haul trucks or loaders and things like that. So then you have this perfect
Yeah.
storm, and then of course their nutrition is just in the tank because they're just throwing everything they can, just to keep awake and stay awake for their shifts and not eating well. So, um, well, walk me through maybe. What are your keystones? We talk about nutrition. We talk about obviously the body's got to be um, having good nutrients coming in, less mechanically distorted. So you're putting people on a protocol of some high dose nutrients, maybe some major auto chemotherapy in the clinic, doing some home, nutritional protocols, things like that. Is that about right?
Yeah, I mean, that's where we start. And I'm assuming we're just talking about people that come in and they feel bad. But,
Sure.
some people come in and they got multiple sclerosis or they got cancer or something. That's a whole nother level of thing that we're not necessarily discussing. But there's so many people before they get to that level, they just, they notice, hey, I don't feel so good. I'm aching and I'm having all these problems. And, what's that all about? Or interestingly enough, Todd, I get a fair amount of people that come in and literally I'm looking at their intake sheet and It says, well, why are you here? And I say, I just want to, I'm healthy and I feel great now. I just want to stay that way. I love those guys. Those are the best guys
They are.
because they're already on it.
Yeah, it's an open door, and it open on their minds is just they've already gone down that pathway,
Yeah.
and that's where you get to play. Yeah, that's incredible.
Yeah.
How Doc, how much would you, and this, you may have some scientific numbers or just what your own gut or experience would lend to this, but how much of these disease states, I mean, you mentioned multiple sclerosis and you got neurological, you got metabolic issues. How much of this is related to genetics, mom and dad, or how much would
Mm.
you relate to more environmental? I guess it's the nature versus nurture question, but with your ability to help a body get back on track, compared to some genetic predisposition, would you say, what would you lend to the majority of these diseases?
In a way, my when people ask me about that, in a way, the response is it sort of doesn't matter in a way because you're not going to change your darn
Hmm.
genetics anyway. So let's just deal with that. But that
Sure.
said, there are two different things that I can quote. One is a very large study that was conducted over the years, and it looked at generational health. And based upon what your great 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 grandmother and grandfather had, and they followed all these generations down to find out who got what and how often and all that. Based upon that particular study, they accounted in general that genetics account for about 4% of the problem. The other thing that they do is they do what we call identical twin studies. So
Yes.
there are identical twins that were born, which have pretty close to exact same genetics, and they were separated at birth for whatever reason. And they track down these guys, and they say, okay, you got Parkinson's disease, and what's the chance that your twin on the other side of the country or wherever they were, in other words, in a different environment, what's the chance that that twin got Parkinson's disease, and or whatever disease they're looking at. And based upon those studies, there are some problems, and I can't recall exactly. I know Parkinson's has about a 30% on identical twin studies, about a 30% genetic. If if you have the
Hmm.
genetics for Parkinson's, there's a 30% chance you're going to get it just from genetics, no matter what you do. Um, but there's a 70% chance you won't. So it does vary, but for the most part, genetics, according to identical twin studies, varies between 20 to about 25% chance of getting ill. So still overwhelmingly, we're still in control of whether we get sick or not to a large extent. And we can compensate for that. So let's say your identical twin did get Parkinson's. Knowing that, we can get very aggressive with protocols to prevent Parkinson's.
That's incredible. Yeah, to be able to identify that and say, hey,
Yeah.
but yeah, but on the flip side, yeah, 70% chance that your environment's going to trigger that.
Yeah.
Um,
So
and
change the
I
environment. Yeah.
Yes, yes, absolutely. And change your oxygen consumption capacity. I mean, bottom line, just like you said, back to the basics. How do you see some of well, it's not really new technology, but new access to ED? And then you mentioned even, some of the genetic, I guess, maybe speak to NAD if you use that and how you see that playing a role. And then even into some new technologies like CRISPR is just a crazy, in my mind, a crazy, and it's a little, you get a little weary on the mRNA packets that they're going in. But I was reading how like sickle cell can be changed where they change the DNA snippets. But also the potential of some of these things, obviously, decreasing the methylation rates of DNA, if you will. Those are big things. But what do you see
Mm-hmm.
as again, go back to NAD if you want to speak to that, and then maybe some future technologies, and where do you see anti-aging medicine going in the next 5 to 10 years?
Yeah, great questions. So NAD is a molecule that's made from niacin, and NAD pretty much drives. There's other molecules that are involved in this, but NAD is the big player. It, in so many ways, controls almost every aspect of how cells work. Now, you make NAD uh, in the mitochondria. That's where it's made. And
Yes.
when you make NAD, the NAD then goes out of the mitochondria, and the cells use it to do all the things that the cells use. But when the NAD is used up, when it's used by the cells, it gets converted to NADH. NADH doesn't do a whole lot. It's got to go back into the mitochondria and get turned back into NAD. So that's how this thing works. So you want to have a
Yes.
lot of NAD, not too much NADH. If your mitochondria aren't producing energy efficiently, you end up with less NAD and more NADH. So ideally, to fix that, you want to get your mitochondria up and running so that you'll make more NAD and have less NADH, because you'll be converting that to NAD. That said, a number of years ago, I had a guy call me up. He was 40 years old at the time, and he's from Southern California, so he went all that close. And he called me up and said, "Look, I'm all messed up. I'm only 20 years old. I'm on disability. I can't do anything." I said, "What's your problem?" He says, "I'm just tired and exhausted. I got no energy. I can't do anything. I've seen all the doctors. They say, that you're healthy. I can't find anything wrong with you." I said, "Well, okay, get on up here. It sounds like you got an energy problem. Let's do some testing and see what we can come up with." He didn't show up right away, but about like 6, 8 months later, he shows up. He walks in the office, and before I see my patients, I always have the energy test. So I'm looking at his energy test, and it's awesome. It's good.
Really?
And I'm thinking, what? How can it be good? So the guy walks in the office, and I said, "Well, okay, nice to meet you. How are you?" He says, "I'm great." I said, "What do you mean you're great? You've been sick for 20 years. He says, "Well, on the way up here, I stopped by a clinic in San Luis Obispo that deals with addictions. And in this clinic, they give you intravenous infusions of NAD every day for 10 days. So on my
Wow.
way up, I had those infusions." He said, "Ever since I had those infusions, I feel like $1,000,000. This
So that was
was
what?
like a miracle.
W-
Totally turned
Absolutely.
this
And
guy around. The NAD
uh,
infusions totally turned this guy. He couldn't make any NAD because his mitochondria is so bad. So
so
what he
shot.
did was he did the NAD that resuscitated his mitochondria, and now, even though he's not getting the NAD anymore, his mitochondria are making it. So it pushed him over the finish line.
Oh, it's kind of like a shock or a way to jumpstart the
Yeah,
mitochondria.
yeah,
That's that.
exactly. So I use NAD a lot in this way. So when people are hurting and need to get a jump start, bang, throw the NAD in there, and it's pretty darn good. The IV is probably the best. The sub Q or IM is okay, but sometimes you get a little edgy from it. The
Yeah,
nasal spray turns out to be pretty good.
really.
But yeah, that can really jumpstart you.
Oh, wow. Um, I'm just curious, how much are you doing at one point? Because I know NAD IVs can be a little bit
Yeah,
rough, or do you start at a lower dose and then kind of build up, or
yeah. We don't like to start any higher than 300 milligrams,
okay,
and we do it very
yeah,
slowly, like 300 milligrams over 3 hours. Now you
sure.
could, once people get used to it, you can do 800 milligrams over 1 hour, but you don't
Sure.
start right off there.
Yeah, I've experimented on myself, and it's an interesting experience for sure. But
Yeah.
all right, well, the
Well, you
last
might have
I
a you might have a problem, Todd, because you're probably in excellent shape, and you probably already have a bunch of NAD, and you might be
hmm
overdosing if a guy like you were to take it. I don't normally
yeah,
give. In fact, I don't ever recall giving NAD to anybody that already has good energy production.
yeah. So that's a good point of really making sure that you understand where you're at, and that bioenergy testing be the main thing that needs to be done.
Yeah.
And so that's a good point. What do you know happens if somebody's already efficient on that and you're flooding the system with NAD? Is that can that have detrimental effects or negative effects on the body?
Um, I assume it would, but since I never
Yeah.
do it, I'm not sure.
No, that's a good point. That's a good point. Well, where do you see anti-aging and technology kind of merging in the next 5 years? I mean, it seems with AI and everything and biotech, it just seems like exponentially things are getting faster and faster and stuff. And I know you're up to speed along with this, even though after 50 years of being in practice, so to speak, practice. I always hate that word, but yeah, in the next 5 years, where are you going with some of this stuff, and what do you see coming down the pipe?
Yeah, well, that's interesting you say that. It's like, yeah, I've been doing this for 50 years, but guess what? I don't hardly know anything. I mean, there's all this new stuff coming out, and I feel like I haven't got out of first grade yet. I'm like in the second half of first grade. So in
Yes.
a sense, it's kind of fun and challenging. But what the thing, I guess the thing that's got me most excited is probably two different things. One is peptides. The
Yes.
the new generation of available peptides, and they keep coming out, and we keep getting more information on peptides, and they're bioregulating peptides that are mostly preventive in action, and then they have regular peptides that can just turn cases around very quickly. And then the other thing that's got me very excited is all the SNPs testing. And at first,
Hmm.
all that's the for the audience, that's single nucleotide polymorphism testing, which is a great word if you want to practice saying it. But what it basically means is there's genetic differences. It's a way to assess various genetic differences in people, so that if you do the right lab uh, and and you know how to process that information, which by the way is not so easy, but
Yes.
then you can get a pretty good heads up on what's the genetic difference between this person and that, and how should I kind of move through that to better suit them. So peptides and these genetic tests, I think right now I think they just show an incredible amount of potential, and I'm still busy trying to keep up with the new stuff that comes out.
To harness it and see which way to go. I love
Yeah.
it. I love it. Well, Doc, it's been an honor and a privilege. I know you're a very, very busy man, and I appreciate you jumping on. I'm gonna see you here soon. I'll try to coordinate and get in. I'd love to just hang out in your environment for a day or two, so I can fly down there
Yeah,
real quick.
pop down, Todd. We'll do a bioenergy test on you, and we'll run you
Yes.
through that. And I think you'll find it very interesting.
Yeah, and maybe it's something I definitely am interested in being able to bottle that up, take that back home, and start doing it
Yeah,
for our local community too.
that'd
So,
be great. I look
okay,
forward to a time when people have access. It's not too many people have access to this easily now. You normally have to travel, which is worth it, by the way. If you're out there listening to
yeah,
me and you're thinking my local doc doesn't have this capability, get on an airplane or get in your car and go get it done. It's that important. And you only have
yes,
to do it typically once every 6 to 12 months initially. And then once you get in great shape, you just do it like every 2 years, just to kind of monitor.
phenomenal, phenomenal. Well, I appreciate you and all you've done for for people in the natural health world and kind of bucking the system. We are all in debt to you, and we'll all benefit for years to come. So.
Okay. All right,
Appreciate
Todd.
it,
Keep up the
Doc.
good work, man.
Uh,
Nice talking with
Will
you.
do. We'll talk. Yeah, likewise.
Okay.
We'll talk soon. All right.
All right.
Bye bye.
Okay. Bye bye.